She has not started party. Oh.
So, greetings and a warm welcome to all the dignitaries present here. I am Kashish from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. And it is with great pride that Clanet serves as the digital partner for this event hosted by the Oncology Integrated Society. And so, the focus of today's session is cervical cancer awareness, prevention, and screening programs. And now, I would like to inaugurate today's session with a Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
And now it's my proud privilege to call upon Dr. Diksha ma'am to proceed with the session. Over to you, ma'am. I welcome you. Thank you so much.
Thank you, Kashish, from the team. Good evening and a very warm and gracious welcome to each and every one of you. It's an immense honor to virtually stand before such distinguished gathering of medical professionals, researchers, and thought leaders, all united by a common goal to empower, educate, eradicate cervical cancer through preventive oncology. Today's enlightening session is brought to you by the Oncology Integrated Research Foundation in proud association with North India Gynae Forum and the esteemed Dr. Chaturvedi Cancer Hospital and Research Institute, Basharatpur, Gorakhpur. Today, together, we strive to strengthen the fight against cervical cancer through knowledge, awareness, and action. Cervical cancer remains one of the most preventable forms of cancer, yet its burden continues to impact countless lives. Prevention, early detection, and timely intervention are our most powerful weapons. And in this noble pursuit, we are privileged to have with us some of the brightest minds in the field, true stalwarts of oncology and gynecological care, who will share their expertise, insights, and latest advancements in preventive strategies. We are deeply honored to welcome our renowned speaker, keynote speaker, Dr. Renuka Gupta ma'am from Max, New Delhi, whose dedication to women's health and oncology has made a profound impact in this domain. Her words undoubtedly serve as a serving guide to today's discussion. Adding to the intellectual richness of this event, we are privileged to have an extraordinary panel of experts who dedicated their lives to cause of women's health. Dr. A.K. Chaturvedi sir, the visionary owner of Dr. Chaturvedi Cancer Hospital and Research Institute, Gorakhpur, whose contributions to cancer care in the region are truly commendable. Dr. Uma Singh ma'am, the esteemed former HOD of KGMC Lucknow, whose expertise has shaped the field of gynecological oncology. Dr. Mridula Sharma ma'am, HOD at Rohilkhand Medical College, Bareilly, a name synonymous with excellence in women's healthcare. Kiran Pandey ma'am, the distinguished former HOD of Kanpur Medical College, whose invaluable insights have been instrumental in advancing gynecological research. Dr. Shabui Qureshi ma'am from KSS Lucknow. Dr. Asha Jain ma'am, Director ma'am from SMSA Raipur. Dr. Reena Srivastav ma'am, the revered former HOD of BRD Medical College, Gorakhpur, a mentor and a guiding force in gynecological oncology. Dr. Amrita Jaipuria ma'am, former president of GOGS Gorakhpur, whose leadership has been pivotal in promoting awareness and preventive strategies. This exceptional panel, with her wealth of knowledge and decades of experience, will illuminate the path forward in preventing, diagnosing, and combating cervical cancer effectively. As we embark on this journey of learning and collaboration, I encourage each one of you to engage actively, ask questions, and take home valuable insights that can be translated into actions. In the words of World Health Organization, cervical cancer is one of the greatest public health failures of our time because it is almost entirely preventable. Today, we stand at the crossroads of change, armed with science, awareness, and a collective will to make a difference. Let this session be more than just an exchange of knowledge. Let it be a catalyst for change. Let us commit today to spreading awareness, advocating for HPV vaccination, encouraging regular screenings, and ensuring access to timely treatment. Together, we can turn the tide against cervical cancer. Together, we can work towards a future where no woman loses her life to this preventable disease. Now, I hand over the virtual dais to Dr. Diksha Chaturvedi, sir, an oncologist behind this Oncology Integrated Research Foundation webinar and owner of Dr. Chaturvedi Cancer Hospital Research Institution, Gorakhpur, privately owned radiation setup unit. Dr. Diksha Chaturvedi, sir.
Thank you, Dr. Diksha. As you know, she has already explained that today we are going to have a webinar on cervical cancer awareness, prevention and screening programs. This month is dedicated to the cervical cancer prevention and education to the public. So we have organized this webinar today, and today's guest of honor is Dr. Sadhana Gupta. Dr. Sadhana Gupta is MS Gold Medalist, MNAMS, FICOG, FICMCH, FICMU. She is Director and Senior Consultant Option Gynae IVF and Imaging Expert, Jeevan Jyoti Multi-Speciality Hospital and Research Center. She is Trustee of Jeevan Jyoti Trust and Paramedical Institute. She has so many affiliations: ICOG Vice Chair Elect 2025, Central Executive ISAR, ISUPER, and SFM, President North India Diagnostic Forum, President Gorakhpur, Chapter ISUPER. She had important positions in FOXI, CEFOG 2018 to 2021, FOXI Vice President 2016.
It's okay. It's
So
okay,
many
Dr.
things,
Chaturvedi. Thank
so
you.
many awards and honors. I will keep on reading, and it will take another 50
Doctor's voice will become crooked, but your
Okay,
awards
fine,
will not
no problem.
end. Your qualification will not
It's
end.
okay.
That's why you
I
are
know. So
valuable.
I welcome you, Dr. Sadhana Gupta. A heartfelt welcome to the esteemed President of North India Diagnostic Forum, Dr. Sadhana Gupta.
Beauty
For the
with brains.
pulse of, yeah, she's beauty with brains, naturally. And with immense admiration and profound respect, we extend a warm and resplendent welcome to a visionary leader and erudite scholar and unparalleled luminary in the field of gynecology, Dr. Sadhana Gupta, a beacon of excellence. She
Thank you, Dr.
epitomizes
Okay, it is
wisdom,
fine.
grace,
Okay.
and so many things. So now we are expecting you for the pulse of wisdom regarding cancer cervix.
Thank you, Deepti. Thank you, AK. Thank you, Diksha. And it is something like a very long personal association with the whole family, and it is the professional association. So hearty congratulations, first of all, to all of you that you are consistently like creating like academic program and making it, which is actually not the interest of a many gynecologists, and it is the thing which we need to look into it. because why you have chosen today the very practical thing. It is not a very high profile oncology. This is something very basic, that is the awareness program, prevention and screening program. And we know at the ground realities, we as a country really lacking into it. So be it a HPV vaccination, so it is still like a costly vaccine. It is government has not approved in the national immunization program, though we have got the indigenous vaccine. So it is going to, again, it is our combined effort and the awareness for the HPV vaccine. One thing which we find, I will be very practical, which all of us must be sharing in life, that people, when we say that you get routine cytology, we go on repeating that every 5 years you get smeared and you get perispeculum examination done, and somehow it is not appealing to a vast majority of people, may it a urban, be it a rural. And if the ultrasound says it is PID, bulky uterus, something, and they are ready to willing for the surgery and something. So it is this lacuna and this like a lot of gaps which we have in our multiple health discipline, that how radiologists communicate, how the midwife or the mid-level health workers say. So this is something which we as a professional body and as a organization, we can have to say repeatedly. So it becomes sometime in hardcore, like the Western world have proved that they can do the regular screening. Even we have failed that it is somehow in the women's health, that whenever there is a health insurance, they say ECG, they say thyroid disorder, their blood, what is the age, but still the pap smear and cytology is not in their insurance system. So there are many things which we have to think, that women health and cervical cancer, which is preventable, what Dr. AK, Dr. Deepti, everybody said, that we are not able to prevent because we are really have failed somehow, be it a government level, be it a professional body level. And we need to say repeatedly what we say. It is an old saying that we have to say repeatedly, because our politicians are deaf. They are a hard hearing. They don't listen to us. So it is something, and many countries have become cervical cancer free. Somehow India is a little receding in the incidence, but still we are quite far away. And one or two important thing, Renuka is with us with all very expert panel, very senior people. That one thing we have to say to our young population, I think Renuka, Reena ji, everybody will agree that the sexual habits, like the adolescent and the youth sexuality, जब हम लोग resident थे, what we used to say, it is a unhygienic condition, unhygienic delivery and early marriage. And now it is a multiple sexual partner, early age of sex. And that is creating a different histopathology. It is a cervical adenocarcinoma, which is little bit difficult to detect with the routine cytology. So lifestyle issue also. So we have to think, and we have to tell to the youth and the youth of India that what is the basic health that we have to speak. So it is screening, it is cytology, we have to speak for the lifestyle issue, for course, because smoking is another thing which increases every cancer. And in our country, or what we say low middle income country, people are less accessible to good quality cancer treatment. So we have more morbidity and mortality in the India and the South Asia. So there are many things, and we have to be really thinking hard, making strategy, speaking. No platform and no time should be lost whenever we are talking to politicians, bureaucrats, our government health programmers, now the NGOs, whatever it is, that it is important. The routine cytology is important. Good sexual habits, safe sexual practices are important. And the girl and boys, especially the girl, need to be vaccinated. So it is a whole-time job. So a lot of thing to do. Renuka is going to do a great job, and all the panel, Dr. Mradula, Dr. Madam Reena ji, Dr. Uma, Shubhu, Kiran, and Amrita, I think they are going to give great inputs. And we have to say again and again, and hearty congratulations, Dr. Deepti, Dr. A.K. Chaturvedi and Diksha, for always be on the move for the prevention and the good management of the gynecological cancer and cancer overall. Thank you very much.
Thank you so
Dr.
much for your
Sadhna.
blessings.
Thank you so much for the
Doctor.
nice words. And you are on the diagnosing end. You are facing the patients in early stage, and we are at the treating end. So we are getting all the patients which are stage 1, 2, 3, 4, everything. So we are improving our part, but this is important. Prevention part is always important, and we have to stress upon it. And all the gynecologists, they must teach, educate, and detect the patient in early stage so that they can be treated fully and the woman can be cured of the disease. So on this topic only, today we are inviting Dr. Renuka Gupta, the Senior Consultant Gynec Oncologist, Fortis Hospital, Shalimar Bagh, Delhi. She is trained oncologist from Tata and Kidwai Memorial Institute, trained in radical laparoscopic surgery under Dr. Shailesh Puntambekar, Joint Secretary of Delhi Gynec Forum, member of Cervical and Breast Cancer Subcommittee, reviewer in many menopausal review journals and Indian journals of gynec oncology and other journals. Special interest is in colposcopy, laparoscopy, ovarian cancer surgeries. She has got various publications and chapters in books and journals. Women Health Leader Award, Oncology 2022. She is Most Trusted Gynae Oncologist of the Year, Healthcare Award 2022. These are all awards which she has received. Global Healthcare Excellence Award 2023. Rashtriya Ekta Puruskar Delhi 2023. Dr. APJ Abdul Kalam Appreciation Award 2023. Namo Gange Healthcare Award 2024, and many more. So now I invite Dr. Renuka Gupta to say a few words on cervical cancer awareness and prevention and screening programs. Dr. Renuka Gupta.
Thank you, sir. Thank you very much for such a kind introduction. So basically, as you all said that cervical cancer, we all know that it is a second most common cancer in women, and we all know that it is eradicable. My slides are moving, ma'am.
अभी तो नहीं. Try again.
Sure, sir.
Yeah.
So are you able to see my slides?
We are able to
Yes.
see, but they are not moving. Yes, we are
It's
seeing.
not moving.
Yeah, cursor is moving.
Trial was good initially. कहाँ अटक गई?
तो उस टाइम तो चेक किया था मैम, तो कह रहा था
कोई बात नहीं, आ जाएगा.
Make it full screen.
हाँ.
अभी मूव
Make it
करा
full
मैं?
screen.
फुल स्क्रीन बोल रही है ना मैम. पहले फुल स्क्रीन
मैम
करो.
मेरे पास तो फुल स्क्रीन आ गया, आपके पास कैसे नहीं?
यहाँ पे नहीं आ रहा.
क्लेरनेट पीपल.
Yes, ma'am.
Hello. Just see. Last time, how did you manage?
Okay, so ma'am, could you please share your screen once?
Yeah.
And could you please go back to the first slide, ma'am?
I'm not able to move even मेरे पास से भी.
So, ma'am, you can do one thing. You can like stop sharing your screen and you can totally like close your
Exit and
presentation. Yes, yes, ma'am.
exit and restart it. That's the only thing.
Okay. So I'll leave the meeting and then restart, no?
Yeah, you'll have to
Yes,
do.
ma'am.
चलो तब तक अपन लोग इंटरैक्ट कर लेते हैं. सर, कैंसर सर्विक्स के केसेस कितने देखते हैं आप लोग सब गायनेकोलॉजिस्ट? डॉक्टर अमृता, एवरी डे?
Actually, what
डॉक्टर
trend I have
अमृता,
observed nowadays, since I came here in 1984, the percentage of cancer cervix was 20 to 26% of gynec cancer, only cancer cervix.
among
Now
all
it has
the
come
cancers.
down, yes, among not all the cancer, only gynec malignancies. Now it has come down
From
to
the
18
total?
to 20, gynec.
Yeah.
Now it has come down to 16 to 20. This is just because of the awareness and improved status of living, cleanliness,
Yeah,
and
lifestyle.
awareness about the cancer. So this is the important aspect. And
And
now
even
for
when
the
people
last 2-3 years, what we are seeing that the incidence of all the diseases has come down, including cancer cervix. Other diseases are increasing, which are not of viral or
non-communicable.
non-communicable. Yes. So this we have observed.
But I think so. पहले भी तो average production of children was 8 to 9 or 7.
Now
7,
it
8,
has
9.
now it has decreased.
3,
Now it has decreased. We
3,
very
4.
rarely see 8, 9, 10.
Hmm.
We very rarely see.
Economic, we
4,
can
5, 6, 4, 5, 6. This is the common finding.
It has decreased so naturally. हाँ, slide आ गई है.
Poverty has improved.
Slide was already there, but slide is not moving. That's the problem. So education and empowerment has also improved in the women. So because the women were earlier considered only as production factory, rather I may say, and now they are educated and empowered. So they know how much to go in for the children and contraception, and they know how to make their living.
Is
And
it moving now?
No darling, बिल्कुल नहीं move हो रही. Stuck
अरे
up.
ऐसे क्या हो रहा है, क्यों नहीं हो रही? पहले तो हो रही थी, हमने जब शेयर करके देखा.
चलो तुम पढ़ के बोलती जाओ. सुन
Your
रही.
internet connection is all right, Renuka?
हाँ मैम, आवाज तो बिल्कुल क्लियर आ रही है.
नहीं, इंटरनेट
अपना
कनेक्शन.
अपना वीडियो बंद करके बस चला के देखो, मे बी.
अभी हो रही है मैम?
अब देखी.
स्लाइड आ गई है, चेंज करके देखो.
तो मेरे पास भी मूव नहीं कर रही.
No, it's not changing.
Yeah, you have been doing so many times.
Ma'am, just a second. I'll
Dance
just
की
call
बात
my
है.
कृषिव, एक बार इधर आएगा बेटा.
हाँ, ये सबसे बढ़िया चीज है.
Do the best.
Children know better.
They know much better. Can't do this.
स्लाइड शेयर नहीं हो रही थी.
Good.
ये भाई जेंजी के जमाने की चीजें हैं. जेन
शेयर होती है तो वो move नहीं कर रही.
आप करिए, अच्छे से करिए, फिर फॉलो करेंगे तो सब होगा.
पता नहीं कैसे हो रहा है, कुछ गड़बड़ हो रहा है.
Good evening, ma'am. Nice to see
Good
you.
evening, good evening. Sorry, I was there, but I could not because
It's okay. Oh, हो गया. अब वीडियो आ गया. Now it's nice to see you.
Good evening, ma'am.
yes, good evening, good evening. There, actually,
Hi,
this is
Kiran.
my. Oh, hello.
Hello.
थोड़ा सा.
Conference की
पावर
तैयारी.
पॉइंट मूव नहीं कर रहा.
अरे बस पूछिए नहीं, इस समय तो बहुत ही मल्टीपल चैलेंजेस आ रहे हैं. ये महाकुंभ ने एक बहुत बड़ा चैलेंज कर दिया है.
सबसे बड़ा.
कितने लोगों ने नहीं,
हाँ, now it's moving.
कितने लोगों ने रजिस्टर
Now
कर
it is
दिया.
changing.
उन्होंने फ्लाइट सोचा बाद में कराएंगे और अब
Now
सडनली
it is
इतनी वो हो
changing.
गई है.
Mic off.
Okay.
This thing.
Okay,
Yeah,
sorry for
fine.
the technical glitches, ma'am.
No,
बेटा
it's
नहीं
fine.
पता
It's
चल भी.
okay.
It's always there, but it's
Thank
okay.
you to the kid who helped.
More important.
So as all said, ma'am, that cervical cancer is, we all know that it is a very common cancer in India, and it is second most common cancer after the breast worldwide. And main cause is that it is caused by a virus, which link has been proven. The Nobel Prize is given to Dr. Haraj Hussain for his role in establishing the link between the HPV infection as well as the cervical carcinoma. So we, as Dr. Sadhna said, that there is multiple sexual partners nowadays because of change of lifestyle, smoking, multiple sexual partners, weak immunity. The main cause is HPV infection. We all know that 130 types are there, out of which 16.
You are muted.
By someone else. Okay. So by basically, ma'am, 16 and 18 is responsible for the 70% of the cases. So
50%.
again, let's stop. Okay, so if I'll talk about the natural history of HPV, we all know it is having a latent infection, then the productive infection. During the latent and productive infection, virus is only in the form of circular DNA, which is not carcinogenic at all. But once it integrated into the host cells, then it starts cellular transformation and start forming the neoplastic cells. And these neoplastic cells still having a various precancerous stages like in a CIN 1, 2, and 3. So these, if we'll see the natural history, we see the patient is having a sexual exposure and then get the HPV infection. If patient immunity is well enough, then this can be reversed in cases of 60 to 70%, and patient can get rid of this infection. But if her immunity is not settled, she is doing smoking or STDs, infections are there. So this infection can remain persistent infection. If the remains infection is persistent, that changes starts through the CIN1. Still, CIN1 can reverse towards a normal infection or towards the normal epithelium, usually within 2 to 3 years. But some point, 10 to 25% of cases of CIN1 still progresses towards the CIN2 or 3. And once the integration of the viral genomes are there, it start converting into the cancer. So from the normal epithelium to become a cancer, it usually takes 8 to 10 years. So we have a sufficient time to screen the patient, because screening guidelines fit into the cervical cancer because it is causative, or we know the causative organism, we know the pre-cancerous stages, if the treatment done in a pre-invasive stage, it can be cured. So it is an ideal thing to do the proper cervical screening. So what these are the basically terms from the normal adenosis CIN 1, 2, 3, and then cancers. Cancer is once that there is a breach in the basement membrane and invasion is there. So it's a long time we have to break the symptoms. So what are the signs and symptoms? Is usually the irregular or post-menopausal bleeding, excessive vaginal discharge, and post-coital bleeding. Severe symptoms are usually when the patient is having advanced stages of cancer. Otherwise, initially patient present with either the post-coital discharge, irregular spotting, or only the vaginal discharge. So we all know about the WHO goal, which is the 90-70-90, means we want prevention by means of vaccination. In 90% of the girls, we wanted to screen the patient at least in 70% of the patient females, and we want to treat the 90% of the patient who diagnosed either the pre-invasive or invasive disease. So at least treatment should be get by the 90% of the females. So what are the steps in prevention? Prevention is having the 3 steps. Primary prevention is HPV vaccination. Secondary prevention is basically by means of screening, that is effective in terms of cytology and HPV tests, and treatment of the precancerous lesion is the tertiary type of prevention. So if we'll follow, there is a various guidelines are there, but in India, FOXI GCPR guidelines we are following, and WHO guidelines are also there to follow. So there are various terms to understand what is see and treat. One is screen and treat, then screen, triage and treat. See and treat is basically a term where a patient is referred to you with a specific report. That patient is having a certain high grade type of lesion, and we'll just see under the colposcopy and treat then and there only. Screen and treat is patient is going for the screening. We'll take the HPV sample, and if there is some via or villi positive, we can treat there and there by means of ablative management. Screen, triage and treat, that we are screening the patient first, then doing the triaging by second test to confirm the finding of first. If second finding is also positive, then we are treating the patient. So this can reduce the over treatment of the patient. So these are the terms used under the guidelines. So what are the screening modalities available? We all know that HPV testing is usually approved by means of the WHO as a primary screening test. But in India, we also use cytology as a primary screening test. But we can use HPV or cytology as a screening test. In a low resources area where the HPV test or cytology means pathologists are not available, we can do even via or villi at the same time, so that they or colposcopy and biopsy can be done. If nursings are trained, they can take the biopsy and send if via positive or villi positive is there. So they can send the biopsy which is read by the expert pathologist. In limited resource countries or settings, usually we do the via and colposcopic biopsies. So what are the target group? Target group is 25 to 65 years of age group. By means of WHO, it is 30 to 65 years. In postmenopausal women, we cannot do the via test because maybe it is not very much effective. Age, when we start the screening at age of 25, up to the age of 25 to 30, we usually screen by means of cytology. After the age of 30, we can do either the co-testing or HPV test usually starts with the HPV test. If we are doing only the primary HPV, we can start testing at 25 also. But WHO recommends start of screening at age of 30. So frequency, if I'll talk about, if we are doing screening only by means of cytology, it should be done every 3 yearly. If it is done by means of co-testing, we have to do this every 5 yearly, because co-testing having a more sensitive, because HPV is more sensitive than the cytology in terms of detection of the pre-invasive lesion. If we are according to the WHO, every 5 yearly we should do. Age to stop is 65 years if all last 15 years screening results are negative. If patient have no prior screening and comes to us even at age of 65, at least you should do one test. If it is negative, then she can exit the screening at the age of 65. If we get any treatment, HPV testing is preferred for the follow-up test at the 12th month after the treatment. If patient is treated for the CIN 2+ lesion, irrespective of the method, means either the cryotherapy or by means of LEEP or by means of hysterectomy, if patient is having abnormal report in more than CIN 2, even in the hysterectomy specimen, she should screen at least for 20 years, because HPV can be harbored even in the vagina and vulva also. Screening in a hysterectomized patient, it is said that if hysterectomy is done for the benign cause, there is no need to do any screening. If there is no history of CIN lesion in previous histories, absence of cervix must be confirmed. If patient is having cervix, supracervical hysterectomy is done, patient has to follow the screening guidelines. If the indication is not clear, then we can do the screening. If findings are there or if symptoms are there, we can do the Walt smear. If patient is came with a report of hysterectomy which shows the CIN, there is no need to do the routine screening, but we have to take the 2 samples at a 6 month and 18 months. If these 2 reports are negative, then patient can exit the screening after the hysterectomy. But if the report is more than CIN 2+, means CIN 3 or microinvasive, she has to follow the guidelines for that screening. So we all know what are the epithelial abnormalities. It is squamous cell atypical squamous cell of unknown significance, that is ASCUS, ASCH, that is and that LSIL, that is low squamous intraepithelial lesion, which is HPV infection basically or mild dysplasia. HSIL means high grade squamous intraepithelial lesion, which usually encompasses the CIN2 or CIN3 now, with suspicious of invasion or squamous cell carcinoma. These are the basically abnormalities which we find in the reports of pap smear or LBC, or the glandular abnormalities. It may be in the form of atypical endocervical cells, endometrial cells, endoglandular cells, or cells which favors the neoplasia, or frank carcinoma is there. So these are the changes in terminologies. Now we are using the two-tier system, that is LSIL and HSIL. In LSIL, we include the CIN1, which is previously termed as mild dysplasia, and HSIL includes the CIN2, CIN3, which includes the severe dysplasia and carcinoma in situ. So there is now two-tier system, either the LSIL or HSIL, but still we are aware about the these terms, CIN1, 2, and 3. So most commonly we are using these terms only. So we did the screening, we did the pap smear, we did the HPV test. So what to do with these tests? So it is important to interpret the results and manage the patient according to the risk of progression to CIN3+. Means the disease which is CIN3+, what is the risk of progression? And we have to set a follow-up protocol for these. So risk of progression with the cytological abnormality, if you see, if patient reports cytology is NILM, means its PAPS is completely normal, the risk of CIN3+ is only 0.26%. While if their LSIL in cytology and patient is HPV positive, risk increases to 6.1%. But if she is HPV negative, risk is only 2%. If the disease is, she is having an ASCUS in the cytology and she is HPV positive, risk is again increased towards the 6.8%. In cases of ASCH, cytology is having alone, the risk is 18%. So these are the criteria how to take the patient, what triage methods should be used for this patient. That is according to the risk of progression towards the CIN3+. If the risk is more than 5%, then we advise colposcopy to the patient. If the risk is only 2 to 5%, repeat testing in 6 to 12 months is recommended. If the risk is only 0.1 to 2%, then we recommend the screening after 3 years. If the risk is very less, then we repeat the test after 5 years. That is routine screening. So what tests should be done for the screening? It depends on the resources which is available to us. According to the FOXY GCPR, or even we'll think that whatever resources is available, maybe in some setup HPV genotype is available, maybe in some setting only the pap smear is available, somewhere only via or villi, maybe in some hospital they keep the colposcope and they do colposcopy after the application of acetic acid for each and every patient. So whatever resources are available, you can do the screening, but usually we do the screening with help of LBC and HPV tests. So these are the common tests we are using. Nowadays, WHO recommended in the newer guidelines that HPV mRNA test. This HPV mRNA test is more specific than the HPV DNA test, because it showed the integrated, it showed that HPV DNA is integrated into the host cell and start producing mRNA. So this is more specific test rather than the sensitive test than the HPV DNA. So these test is acceptable for the 3 to 64 years of age group, more sensitive and less specific than the cytology, but mRNA is even specific than the HPV DNA test. If patient is HPV negative, then what to do? We have to do only the routine screening, that is at the interval of 5 years. If patient is HPV, then again, this is a sensitive but not very specific test. So to avoid the over treatment, we have to do the triaging of the patient, either by means of the cytology or via or the genotyping. So we have to do via test or the genotyping or the cytology. If patient is HPV positive or via positive along with HPV positive, and or the genotyping 16, 18 is positive, or so whatever is available with you, you can go for that test. If these are positive, then definitely should go for the colposcopy and biopsy. And patient, if she is eligible for ablation, you can do ablation at that point. It is WHO criteria that we can do ablation for the HPV positive even if the colposcopy is negative, normal. If patient is not eligible for the ablation, then you can do the excision procedure if you have according to the WHO. If patient is having genotyping which is other than 16 and 18, patient is VIA negative or cytology is normal, then in these patients we can repeat the HPV after 1 year. If again after 1 year patient having a HPV positive, means 2 consecutive HPV DNA positive, then we can perform the colposcopy. If colposcopy is normal, then again the HPV after 1 year. If HPV is negative, then we can do the routine screening. But if repeated HPV is positive, definitely we should go for the ablative or excisional procedure. Eligibility criteria for the ablative methods are basically there should be no suspicious invasive lesion or glandular lesion, any adenocarcinoma or adenocarcinoma in situ. The transformation zone should be fully visible. The whole lesion should be visible and it should not extend into the endocervix. And lesion is type 1 transformation zone. So in this patient, you can see she is just 38 years old, HPV positive, her cytology is normal. So colposcopy is done. We can see there is no specific finding in the colposcopy. These are the usually metaplastic lesions only. So we can do the cryotherapy. That is a method of ablative therapy in this patient just for the relief of the symptoms to the patient. So what is co-testing? Co-testing is HPV plus cytology. We are recommending these tests for the 30 to 64 years. It is a preferred screening method if resources are available, to be repeated in 5 years because detection rates are quite high because sensitivity increases as well as the specificity also increased. So in the woman with positive cytology and negative HPV test, we have to follow the cytology report rather than the HPV because cytology is more specific than HPV. If patient is HPV negative and cytology is normal, then we can go for the routine screening. If patient is HPV positive and cytology is also abnormal, that is more than ascus, then we have to go for the colposcopy and biopsy. But if patient is HPV negative and patient is having only low grade lesion, that is ascus or LSIL, we can repeat the co-testing after 1 year according to the protocol ascus or LSIL. If the HPV is negative but high grade lesion, ASCH or HSIL, definitely send the patient for the colposcopy and biopsy. These all criteria are according to the risk of progression in 5 years for the CIN3 plus lesion. If you are using cytology only as a primary screening modality, then it should be advisable for the 21 to 65 years. We have to repeat in every 3 years. And the terminologies used are the Bethesda system, which is recently revised in 2014. We are using standardly the Bethesda system for the cytology. So WHO also recommended that if we are doing the screening with the cytology, if it is negative, screening in 3 years. If it is more than ascus, then do the colposcopy and biopsy or the manage according to the ablation or histopathological diagnosis. If there is ascus, then do the triage with HPV. HPV positive, go for the colposcopy. HPV negative, routine screening in 3 years. So this is the basically WHO cytology program. So again, she's a case, other case, she's 38 years para to light to with discharge PV. Her cytology is ascus. So HPV DNA was done for the triaging, which is positive. So I'll do the treatment. So ascus usually see in 2.8% of the smears and risk of HPV positive ascus in HPV positive. There is a patient is ascus positive as well as the HPV positive. There is a higher risk of having a high grade abnormality in this patient. So risk of CIN2 plus lesion is 18% if HPV is positive, while it is only 1.1% if patient is HPV negative. So definitely we should go for the triage by means of reflex HPV testing, or we can do the repeat cytology after 1 year or do the colposcopy if patient is non-compliant. So what do we have to do? If HPV is not available for the non-compliant patient, definitely do the colposcopy via and biopsy. If patient is compliant, we can do either the cytology after 1 year if we don't have a HPV facility, or if report is more than ASCAS, then definitely go for the colposcopy. If we are having a HPV availability, then the HPV positive patient go for the colposcopy. In ASCAS positive, HPV negative, we can go for the routine screening because the risk is only 1.1%. So she underwent the colposcopy because she is HPV positive, and we can see there is no much findings are there, only small acetocyte areas are there, and biopsy was done for this area, and biopsy is CIN1. So how to deal the CIN1? CIN1 is again a low grade lesion depending on the previous cytology report. If she is having a high grade lesions, so we can do the co-testing at 1 to 2 years or cytology 6 monthly, or we can go for the diagnostic procedure if patient is not very compliant. But if patient is having a previous low grade kind of lesions in her cytology reports, we can do the co-testing or cytology at 1 year and 2 year interval. If both tests are negative, she can undergo the routine screening. So for the patient who is CIN1 on histology, we can follow these patients usually up to 2 years. If the results after 2 years is again low grade cytology, definitely we have to treat either means of the ablative method or by means of excisional method, whatever is the criteria patient suits in. So again, she is a case of para 2 live 2, 37-year-old with discharged PV, LBC is LSIL, HPV DNA is positive. So definitely colposcopy is recommended. So LSIL is found only in the 0.97% of the cytology. In these patients, 80% patients are usually HPV positive. The risk of LSIL alone cytology, CIN3 plus risk is 5.2%. But if patient is HPV positive along with LSIL, I already told risk is 19%, which is very high. If patient is LSIL and HPV negative, risk is 2%, that is less than 5%. So we can follow these patients. So what are the recommendations? We can do the HPV triaging. If positive, go for the colposcopy. If negative, we can repeat the co-testing at 1 year. If HPV is not available, definitely patient should be referred for the colposcopy, or you can do the colposcopy. In non-compliant patient, do the colposcopy via, if possible, do the ablation or excisional procedure. So in this patient, colposcopy was done. So you can see there is a acetocyte area is present, and this is the comparatively large acetocyte area, which is not, we are not able to cover this area with the ablation probe. So patient is symptomatic with excessive discharge and she is quite apprehensive. So a leap was done for this patient and report is still CIN1 after the leap. So again, what to do in patient who is, she is having a LSIL with young patient, that is 28 years old para 1 live 1 patient with LSIL. What to do in these patients? Should we do the HPV DNA, or we do the repeat cytology, or do the colposcopy? What to do? She is quite young. So guideline says that the young patients are mostly having a HPV infection. So in young patient, it is not recommended to do the HPV testing because most of the patient are HPV positive. Incidence is very high for the HPV, that is 40.4%. And 70% of CIN2 lesion even regressed in this young age group, and progression is very less, that is only 0.5%. So in these patients, what to do? We can repeat the cytology annually for the 2 years. If report is more than ASCAS, then go for the colposcopy and biopsy. If the report is normal, you can repeat the cytology at 3 years. If it is again negative, then the routine screening after 5 years. In non-compliant patient, definitely even in the young patient, we have to go for the colposcopy and biopsy. So in this patient, last 2 annual cytology reports are LSIL. So we did the colposcopy, but you can see nothing is there. And this is just the metaplasia and the cervicitis only. So she can be kept under the follow-up. So again, our next case is 37 years para 2 live 2 HSIL. Then how to proceed? Should we do HPV DNA, or we can left the patient for the repeat cytology after 1, or we have to do the immediate colposcopy? Definitely, we have to go for the immediate colposcopy because risk in HSIL is very high. and there is no need to take HPV test in these patients because risk is alone for the cytology is very high, that is 47%. Even we can found the invasive carcinoma in 7.3% of the cases of HSIL or ASCUS or ACH. So there is no need to take the HPV DNA testing. If as ACH or HSIL, go for the colposcopy biopsy along with the ECC because sometimes lesion is there into the endocervical canal. If the ASCUS or HSIL patient age is more than 30 years, your colposcopy is adequate and you are suspecting only the lesion which is less than CIN1, then we can do the repeat co-testing after 1 year, or we can do the excision if patient is non-compliant. If lesion is CIN2 or 3, definitely go for the excisional or ablative procedure. This is screen and treat type of method or see and treat type of method. If the colposcopy is inadequate, definitely excisional procedure should be done because we are not able to see inside the cervical canal. And follow the HPE report, and we have to follow the guidelines. So in this patient, you can see she is presented with the HSIL, and here you can see the thick acetovite area is there. So here we are not able to see exactly the margin because lesion is very high. So LEAP is done for this patient with she is having a HSIL with pre-margin. She is under follow-up now. So what is the management of CIN2 or 3 on histology? Definitely we have to do the colposcopy biopsy, and biopsy confirm the CIN2 and 3. But we have to review the colposcopy report. If it is adequate, excision should be done because this is the only under the punch biopsy. We have not done the excisional procedure. This is for the punch biopsy. Then we have to treat this patient. We have to review the colposcopy. If colposcopy is inadequate, definitely excisional procedure should be done. If colposcopy is adequate, we can do the excisional procedure as well as the ablative procedure. After doing any procedure, we have to do the repeat HPV and cytology at 1 year and 2 years. 2 test negative, then repeat at 3 years. If 3 test negative, then routine screening. So 1 year, 2 year, then after 3 years, then after 5 years. So every 5 yearly, then we can go for the routine screening. If we are doing the cone diagnostic excisional procedure and margins are positive, definitely we have to follow the guidelines. We have to either revise the margins or we have to do the repeat cytology and ECC 6 monthly according to the age, margins and lesion with the colposcopy. What to do if a very young patient presented with the HSIL? A young patient with postcoital bleeding presented with HSIL. So definitely, even a young patient present, we have to go for the colposcopy and biopsy and ECC because we have to rule out the invasive cancer. Once you have ruled out the invasive cancer, then definitely we can do the follow-up. If there is no CIN2 or 3 lesion, then we can do the cytology, colposcopy at the 6-month interval. If there is persistent HSIL in for the 2 years, definitely we have to go for the excisional procedure. If the lesion is CIN2 or 3, excisional procedure is must in patient with HSIL. So you can see this is the colposcopic finding of the same patient. Very high grade lesion is there, and these are the minor lesion, but this is a very high grade lesion. So HSI colposcopy, under colposcopy LEAP was done and margins are free, ECC is negative, and still the patient is under observation. As family is complete, so that she doesn't need any completion of family now, and she's still coming for the regular checkups. So this is a small video. I think it's not working. It's a so it's a video of LEAP. We can see the application of acetic acid. But application of acetic acid, just to see the effect of acetic acid, then the Lugol's iodine application usually lasts longer. So she is having a abnormal area in the posterior vaginal wall. She is not the same patient. The video is of some other patient. We have to do the sounding. Hemostatic suture should be taken in 3 o'clock as well as the 9 o'clock position. I usually prefer this suture because bleeding is very less after this suture. So it usually gives immense hemostatic effects. And then we have to choose the loop according to the size of the lesion, and we try to take the central part with the lesion in a single go, and we have to orient this lesion so that pathologists should know when they are doing reporting. So usually I'll try to mark the suture at 12 o'clock position and inform my pathologist that what bite I have taken. This is a central specimen I have taken, and as the posterior lesion is much bigger than the anterior lesion, posterior part is removed more, and anterior portion also I'll take with the extra smaller loop as a extra margins. Even the posterior margins are also taken just to confirm that margin should be negative, because we cannot repeat the procedures. If patient is young, definitely we are apprehensive, then we can go for the frozen section for the margins, and we have to remove at least 1 centimeter should be removed, because the pathology said that the disease is usually up to the 7 millimeter depth in cases of even the microinvasive cervical cancer. So at least 1 centimeter depth should be removed. Now this is a deep margins I have taken with a smaller loop, and now coagulation is done by means of the ball cautery. So complete hemostasis is taken. So this is the leaf wound, and usually follow patient is after 1 week and after the next periods. So little bit about the atypical glandular cells. If the pap smear shows the atypical glandular cells, there are chances of adenocarcinoma in 12.7%, ovarian carcinoma is 1.4% patient, and cervical adenocarcinoma in 0.9%. So chances of endometrial carcinomas are comparatively higher. So when there is atypical endometrial cells are there, definitely go for the endometrial biopsy and ECC. If endometrial pathology is there, definitely we have to work up according to them. If there is no endometrial pathology, then go for the colposcopy and biopsy. If atypical endocervical cells are there, definitely go for the colposcopy and biopsy. If colposcopy is normal, biopsies are normal, then you can do the follow-up for these patients by means of co-testing after 1 year and 2 years. But if you found the CIN 2 or 3 lesion, then definitely you should go for the excisional procedure, and depth of the complete endocervical canal just below the internal os should be removed, because glands are present up to the internal cervical os. So if there is AGC which favors the neoplasia or adenocarcinoma in situ, definitely we have to take the multiple biopsies. We should go for the colposcopy, take the cervical biopsy, endometrial sampling, as well as the endocervical sampling for these patients. So this is again flow chart, which is both the Foxy GCP are for the same. So the thing to be kept in the mind, and whenever we are doing the diagnostic excisional procedure for the glandular lesion, it should not be fragmented, and there should be no cautery artifact. So cold night conization is preferred in these kind of patient. Small video of cold night conization is there. She is the patient who is having a very huge hypertrophic cervix, and there is no exactly we cannot see the big lesion in this, only the small acetobite area is there, but she is having the atypical glandular cell and big cervix. Family is completed. So again I have taken the 6 and 9 o'clock position, and we just mark the margins with the knife, then remove the colposcope. Definitely cold knife conization is having little bleeding is there, because we are using knife. So we use the cautery to coagulate the bleeders, and we have to remove the complete cervix in a single piece. So at least 1 centimeter depth should be removed for these patients. So what if patient is pregnant? What if patient is having a low grade lesion, and what if patient is having a high grade lesion? So a main motive is to exclude the cancer in these patients. So routine screening is recommended in the pregnancy. Endocervical brush should not be used. Colposcopy should be done if patient is having more than ascus in her cytology. Our purpose is to rule out the malignancy. If CIN1 in biopsy, we can do the follow-up in postpartum period. CIN2 or 3, we can go for the excisional procedure, superficial excisional procedure. Don't do the ECC in these patients. These are quite safe. If you are having suspicion of cancer, only then take the biopsy. If you don't have any suspicion, there is no need to take the biopsy. We can follow these patients after the postpartum period, because in pregnancy, usually the cervical changes are like that, but we are having a usually one step higher findings rather than the, because of changes of hormones, changes of cellular changes because of the hormone changes in the pregnancy. So we have to be conservative, but definitely we have to rule out the invasive cancer in these patients. So review the colposcopy. If suggestive of invasive cancer, you can do the excisional procedure and treat after the pregnancy. But if there is adequate colposcopy, then we can treat, no, sorry, if colposcopy is adequate and there is no suggestive of invasive cancer, then treat the patient after pregnancy. But if any invasive component is there or colposcopy is inadequate and you are suspicion of the any invasive lesion, definitely take the excisional procedure. And if cancer is there, we have to do the definitive treatment as per period of gestation. So a little bit about the prophylactic vaccine. These because we know the infection is cancer is caused by the HPV virus. So it can be prevented by means of HPV vaccine, which is virus-like formed by the virus-like particles of the L1 capsid, which is DNA free, but very similar into the structure and immunogenicity of the authentic papilloma virus. These are highly immunogenic, non-infectious, non-oncogenic. Two types are available, that is quadrivalent and nanovalent. Both are available in India. In quadrivalent, even Bharat Serum vaccine started the formation of Cervavac, which is comparatively cheaper, not much cheaper, but still comparatively cheaper than the Gardasil. So 3 doses, that is 0.5 ml each, intramuscular and over the deltoid. Schedule is 0 to 6 or 016. Second dose is usually 1 to 2 months after the first dose. Third dose is 6 months after the first dose. The minimum interval should between the first and second dose is 4 weeks. And between the second and third dose is 12 weeks, and first and third dose is 24 weeks. Vaccination has no therapeutic effect. There is on the pre-existing HPV infection. So patient if already having a HPV infection, it cannot provide the protection against that virus. Pre-vaccination assessment to establish the appropriateness of the HPV vaccine is not recommended. Means there is no need to do the HPV test first before giving a vaccine. It should not be given to the pregnant woman. It is category B drug. Either there is no teratogenic effect yet shown if accidental vaccination is given. It can be given into the lactating woman. Recommended age is 9 to 45 years of age. Vaccination at age of 9 to 14. Only 2 doses are sufficient at 0 and 6 months. But after age of 15, 3 doses is needed. It can be given to the boys, which is recommended to 9 to 26 years of age. That is 2 doses up to 9 to 14 years of boys, and 3 doses for the 15 to 26 years of boys. So Cervavac is gender neutral vaccine, and Gardasil 9 is preferred for the boys and only recommended. Gardasil 4 is not recommended for boys till date. So take home message is HPV test is a preferred for the primary screening. Colposcopy is the best method for the triage. Screen and treat means primary HPV positive test. Treat with the ablative or excisional procedure depending on the transformation zone. Screening, triage and treat means primary positive HPV screening. Need undergo the second triage test by means of cytology, genotyping and colposcopy before the treatment. Screen, triage and treat decreases the over treatment. So if patient is HPV positive, go for the cytology, genotyping via or colposcopy. If ascus is there, go for the HPV testing via or colposcopy. If LSIL is there, you can go for the HPV or colposcopy for the triage. In cases of ASCH or HSIL, definitely go for the colposcopy and biopsy. In a glandular cells, definitely you have to evaluate the endometrium as well as the endocervix. More than ascus in pregnancy, go for the colposcopy to rule out the malignancy. HPV vaccine is effective and recommended to prevent the HPV related cancer. Thank you.
Thank you, Dr. Renuka Gupta. It was really an elaborative, informative, and mind exercising.
Definitely, ma'am. मतलब screening guidelines are so
It's,
vast.
it's very nice and nicely presented. And really, it's a very eye opener for the few gynecologists as well. And it's good, 1 to 2 doses, 9 to 14 years. One thing is important that it is not a treatment, it's for the prevention of the
Only prophylaxis.
disease. So if a person is having HIV, HPV infection, it's not going to, neither it is going to harm her or nor much of effect. So
Benefit.
we have to start it before the infection is the chances of infections are there. That's why it is age is 9 years before the sexual activity starts. So it's very nice presentation. Thank you so much, Dr. Renuka Gupta. Now we as we are running short of time, we are having our expert panel. So we invite Dr. Reena Srivastava. She was ex-HOD and past president of UP chapter of Gynae, president of Gorakhpur Menopause Society. She was facilitated by FOXC, American Cancer Society, Cancer Foundation of India as a coordinator, HPV vaccination.
Favorite man.
Thank you,
Let
Dr.
us have a
Chaturvedi.
comments.
So we need few expert comment from you, madam. We invite you for the
Yes,
expert comment.
a very elaborative deliberation by Dr. Renuka. Thank you. You have given each and every step and each and every situation has been described, be it young, be it pregnant, what to do and what not. The gist for screening. See, people might have thought that it is too cumbersome to remember the flow chart, but actually what you need to know is that one test for screening is required. Nowadays, HPV is said to be best, but whatever screening you can afford for your patient is to be given to that patient, number one. And once it comes to be positive and especially higher lesions, then you have to try it with the different test, maybe colposcopy, maybe cytology, whatever the situation tells you. And the screen and treat, the see and treat approach is for the camps. If you are going to the camps, go there, you examine the cervix. If you find a white lesion over there, immediately you can do a ablative lesion, if at all suitable for ablation. That is immediate treatment for those cases who can't come for follow-up regularly, and better to treat it there. That was one part. The other part was triage and treat for the patients who can come to us for follow-up. We do a triage, we reassess the lesion. If at all, yes, it is a high-grade lesion, we have to treat either by ablation or excision. Simultaneously, we have to take care in the cytology whether we are having any atypical glandular cells. Then we have to approach the endocervical canal and the endometrial cavity also. So the gist for screening was all that. You have to confirm, reconfirm, and then go for testing so that the lesion does not progress to more than CIN3. This is the basic aim. And we have got a window period of a very large window period of say 8 to 10 years, maybe 13 years also. So better to treat so that we don't get an invasive cancer. This is the aim for the prevention of CS cervix, and it is a very good opportunity. Each and every woman should be submitted to screening, although it is what we are doing nowadays is only opportunistic screening. People are not coming off their own to get the treatment. Maybe in metros there are people who do come, but in our area people don't come for screening. We are doing opportunistic screening. So it is just drop in the ocean.
Nowhere they are coming for a
Renuka
screening.
wants to say something.
Ma'am, even in the metro cities, there's no one who is ready for the screening, regular screening. Even
They don't want to go for it. They find it cumbersome. Why should I get it done? I don't have any problem. There are so many things in their mind. Even the educated people don't come. We have taken a lot of awareness programs in the university, in the clubs. Amrita was there. People are not interested for screening. So the WHO goal, what I find in our country, is going to be difficult, very, very difficult. Vaccination is going to serve, it is easier. And it is, if the mindset is there that yes, we should vaccinate our girls, between 9 to 14, that is going to give the best answer.
पर
But
वो भी
till
नहीं है मैम
the whole, all the girls and boys are getting vaccinated till whole.
नहीं डालेंगे ना तब तक नहीं हो पाएगा.
Yes.
जब तक अब we'll don't include.
That is what I am saying. That till we are able to vaccinate the boys and girls just like any vaccination in the childhood, we have to continue screening. We have to continue screening. Without that,
I think the vaccination must be made compulsory in the pockets where the incidence is very high.
it is. Niti
Everybody must
Aayog
be
has already
vaccinated.
recommended it,
Yeah,
Dr.
yeah,
And
yeah.
it is just going to come in the universal immunization program, say next year. Till then, we are taking awareness program of doctors.
Yes.
Till now, we have
We are
made
educating general public
trained
and
around
doctors as well.
10,000 gynecologists for
मैडम को तो
vaccination.
अवार्ड भी मिला है इस चीज का.
Yeah,
And
that's what I
now
told.
the second phase is there. We are going to train the IMA doctor. Gorakhpur mein bhi aayenge.
Yes, yes,
So,
that is important. Doctors must be
IMA ke
educated.
saath
That's
we have signed a MOU with IMA, the president, and we are going to train the doctors so that every person knows the same schedule to be given to the female or a girl. ये नहीं कि हम एक लगाएंगे, हम दो लगाएंगे, हम तीन लगाएंगे. WHO is recommending one,
Something
but
else.
we have to follow the rules of our land. Till now, one dose has not been recommended by our government. So we have to give 2 doses in 9 to 15 and beyond that 3 doses. Gardasil is saying 3 doses even between 9 to 15. So we have to follow all that. So that similar thing has to be propagated in all the doctors
everywhere.
and then definitely to the paramedicals. So we are on way, but 90, 70, 90 till 2030, what do you say? Will it be possible in our land?
No, never. अभी तो 50 है, 4th पहुंच जाए बहुत बड़ी बात है.
अभी हम बिल्कुल जरा सा भी नहीं चल पाए हैं. The screening program is less than 2% in India.
Exactly.
But then we have to be
started
aware
this
and we
type
have
of
to make the
programs.
people aware. I don't know when that time will come. That we will stop losing 77,000, more than 77,000 females a year of cancer cervix. लेकिन बहुत कुछ हुआ है. जब हम लोग देखते थे तो आए दिन एक कैंसर सर्विक्स लास्ट स्टेज में मिलता था. Now even the women have become aware. जरा सा discharge होता है, they run to a doctor. Whosoever can come.
Because earlier when
it
I
has
was
made a
student,
difference. The cancer, what we find these cases in late stages 3, 4, the number is very less than before.
In 1980s or 70s, we used to see very advanced cases because in the gynec department, they just peep in and say, oh, this is cancer, send it to the cancer hospital. They don't even bother to see the, do the PV or anything, just send them. So thank you so much. Thank you so much.
We used to do a biopsy only, then we used to send.
Yeah. Now I will like to have some expert comment from Dr. Uma Singh. Dr. Uma Singh
who all are there? You just talk about.
I don't see Uma over here. Kiran is there. Dr. Kiran is there.
Yes.
Dr. Kiran is here. Yeah. So I invite Dr. Kiran for her expert opinion because paucity of time.
She is also a magnanimous lady with bright brains and
Kiran is muted.
Madam, you are muted.
I think.
Madam, you are not seen also.
She was there just a few minutes back.
Dr. Nasing was also there. I don't know.
Dr. Sonia is there. Dr. Sonia, please show yourself. Dr. Sonia, please show up yourself. चलो अमृता तुम ही बोलो कुछ.
Dr. Amrita.
क्या किया है पिछले साल तुमने? बहुत टीचिंग क्लासेस ली हैं.
Well, thanks for the opportunity, Dr. Deepti, and congratulations for a great program. And Dr. Renuka, your talk was very nice and very elaborate and very, very informative. So, I mean, I'll come to your slides later, but talking about the screening, everything has been discussed by you and Reena ma'am. It's just one word one thing I would like to say is that what you said, it was if a post-hysterectomy case is there with a benign lesion, she doesn't need to be screened. But I would just say, for the benefit of the audience, that if she comes with any complaint, that is postmenopausal bleeding or something like that, she should be screened then. Because there are many patients, they come with a benign report, but they still have problems.
Yeah.
And
That's very right.
yes, sir.
Yeah,
And
yes.
talking about over-treatment of the patient that you told about the triaging, etc. So it's good, but at our places, patients, ladies are already being over-treated. Just for a discharge or a mild lesion of the cervix, they are suggested hysterectomy and they run to the hospital. So if we take a long time in screening them, doing a co-testing, etc., or a biopsy, and something like, sorry, not a biopsy, a screening, LBC, HPV, etc., what we do is, what I practically do is, I straight away do a colposcopy and a biopsy. I don't go for a LBC or something. And they have a report that it is a benign lesion. They do not have a cancer. And then they are happy and confident about it.
I already mentioned, ma'am, some patient having, some doctors having colposcope in their clinic, so they directly do the colposcopy. Definitely, it's a good option.
Yes, ma'am. So vaccination, of course, it's good and we should be optimistic about it. And we are having an incidence of 16 per 100,000 right now of cancer cervix. We want to bring it down to 4 per 100,000 till 2030. So whatever all of us are doing, starting from these discussions or training the doctors and everybody else, I think we will definitely achieve the goal. Maybe not at 2030, 2050, but definitely we will. And screening, vaccination is okay. And regarding the vaccination also, what I feel, people say that if a woman comes to us and she wants to get vaccinated, we do not force her, or we do not need to do a screening upon her. But in my view, what I feel, that she should undergo screening prior to vaccination, because after the vaccination, if she is found to have if she is found to be HPV positive or some early lesion, then it will go against the vaccination, that it is not effective. This is my view. Ma'am, you say what you want to say.
Basically, when you are giving a vaccine to a person more than 15 years, any girl or woman or whatever the lady is, suppose she is 30 years and she wants a vaccine, we have to counsel her that if you are already infected, this vaccine might not help you. There are a wide variety of HPV DNAs, and it is covering 4 or maybe 9, whatever you are giving, whatever vaccine you are giving. They are going to cover those. But if you are infected with it previously, this vaccine is not going to work. If you tell this thing properly, then this problem will not arise.
But ma'am, is counseling enough? Shouldn't we have a document in our hand?
There is
Well,
nowadays,
that can be done. If a patient can afford, yes, you can go for it. But then
Yes.
counseling will work, and counseling से patient को तो हम बता सकते हैं ना कि अगर आपका see, it is recommended for best recommendation is 9 to 14 years. Beyond that, if you are already infected, it might not work. ये तो हम पूरा उसको समझाएंगे ही. Still, if she wants to be very, very confident about it, then you can get it tested.
One problem will arise if after 15 years or 18 years of age, you give vaccine by saying that if you are suffering from HIV. So first we have to confirm whether she is suffering from HIV or not.
HPV.
No, we are not talking of HIV. We are talking of HPV.
Sorry, HPV. So,
see, to make the things easy, the vaccination easy, this schedule is there to give it to anybody, whosoever it is, maybe positive, maybe negative. And
Maybe
with a
negative.
very good counseling, that if you are sexually active, you might have already had that,
Attracted.
you
Yes.
might be having that infection. So this vaccine will not be, definitely, it is best effective when it is given between 9 to 14. That is around, you can say 90%. And the vaccination effect goes down as the age increases, and goes down to say 60% when even the girl is 18 years. So all
Yes.
that has to be told to the person who is going to take the
Counseling is
vaccine.
always important.
Yes. So this counseling is very, very important. Or agar if she wants to get it tested, let her be tested, no problem. But to make it easy,
Yes.
vaccination is going to be taken into the universal program. So for all the girls 9 to 14, after 9 to
Yes,
26,
madam,
again 3
irrespective of
doses. So
positivity.
how many of them you are going to screen?
9 to
That's
14
why
तो
this
ठीक है
schedule is
मैम,
there.
9 to 14 ठीक है,
19, 14
इस
ठीक
वाले
है
प्रोग्राम
अंदर।
लेकिन
में गवर्नमेंट
जो
ले ले
जो 3 वैक्सीन लगवा सकता है वो स्क्रीनिंग ऑफ, मतलब ये मेरा दिमाग की बात है, ऐसे नहीं है।
नहीं
And
दिमाग
That
ठीक
will
चल रहा
create a
है।
confusion. I think we should
तुम्हारा दिमाग
blend.
बिल्कुल ठीक चल रहा है,
अच्छा चल रहा
बट
है, चिंता मत।
ये काउंसलिंग करने के
counseling
बाद अगर कोई
also
क्वेश्चन
important.
पुट अप करता है कि मैडम मेरे में है
Then
कि
you
नहीं,
can explain.
यस यू कैन गेट योरसेल्फ टेस्टेड, करवा लो, कोई
Yeah.
बात नहीं।
Then
ये
you
तो
can explain.
vaccination के
But
time
then this should not be a rule for all, no? Though it is going
हाँ,
to be cumbersome for everybody.
we
Recommendation
have
वो
to,
होते हैं जो easily put हम सबके ऊपर वो कर सकते
लागू
हैं,
कर
यूज कर
सकते
सकते
हैं।
हैं।
बट मैम एडवाइस तो करना चाहिए कि सेक्सुअली एक्टिविटी के बाद आपको स्क्रीनिंग रेगुलर करानी है। वैक्सीनेशन कैन नॉट प्रिवेंट द स्क्रीनिंग।
Yeah, screening is best for that.
एंड कमिंग टू योर स्लाइड्स रेणुका जी, प्रॉब्ली आपने जो फर्स्ट केस दिखाया ना, वो आपने बोला कि कोई लीजन नहीं है, बट आई थिंक वो CIN1 था।
मैम दैट इज नहीं, फर्स्ट केस जो दिखाया था मैम,
फर्स्ट केस, हाँ, जो आपने उसमें
क्रायोथेरेपी था मैम।
उसकी एसिटोवाइट जो था वो ज्यादा था,
That
मार्जिन
is
उसके
the acetobightness is because of chronic cervicitis. Basically, उसमें ना मैम,
वही,
it's
हाँ,
not
she
this kind
said.
of dysplasia. This is
So that was
more
not the
of-
first slide,
Even
Renuka.
I
She
was
is talking
thinking
of
in
the first
between
slide.
that.
केस वन जो था
Yes,
मैम।
ma'am. Case 1 is basically immature metaplasia.
अच्छा, नहीं वो मिल्की नहीं था मैम, वो एकदम वाइट था, मार्जिन
And
उसके
the
बेस।
endocervix था. If you see, that was only the endocervix.
We can just go through it again.
Oh, फिर वही। Moving, ma'am, slides.
हाँ।
Yeah, moving.
ये नहीं मैम।
There is also one more dialogue about dual stain.
Ma'am, this.
ये वाला, हाँ
हाँ,
ये मैम।
Ma'am, this is basically the metaplasia only.
metaplasia.
It is more than metaplasia, in my opinion, Renuka.
Yes,
हाँ,
yes.
It is
क्योंकि
case
वो
not
even
metaplasia. This is
Lugol-Sidin,
endocervix.
Metaplasia has
No,
to be
ma'am.
very cloudy, sort of
आप-
thin, cloudy
No,
lesion.
Milk.
ma'am. No, ma'am. This is only the endocervix because you actually ये सिर्फ acetobite और iodine negative picture है। हमें मैम कंपेयर करना होगा तो हमें initial. This is endocervical.
कभी मैडम वो जैसे साड़ी का कलर
After how many minutes it was taken?
हाँ,
The picture was taken after how many minutes of application? That is also important.
This is 57 seconds.
57 seconds.
it is 2 minutes.
2
2
minutes.
मिनट वेट करिए.
Ma'am,
Then-
Because
it is
before
said only
हाँ.
you have to wait usually 45 seconds. 45 seconds पे असर आना
हाँ.
शुरू हो जाता है. At what early it is appearing.
हाँ, वही कह रही हूँ ना, पिक्चर कब
How
लिया है.
early it is
इसमें
disappearing.
वेसल्स भी दिख रही हैं मुझे तो, आई मीन
And
आपने
these are not
ठीक है।
vessels. These are the glands opening only.
हाँ, नहीं ग्रीन फिल्टर लगता तो पता लगता
मैम
है।
इसमें ग्रीन फिल्टर नहीं शो किया ना मैंने.
मैं actually I will like to say
It is all endocervix, what I feel. And
This is
that is
endocervix
ectropion
basically, and
sort of lesion is.
Yeah,
huh?
yes, ma'am.
हो
Ectopy sort of.
सकता है।
It is
Okay,
ectropion and it is endocervix. And if an early picture is taken, it will seem to be white. This type of
हाँ।
whiteness will be seen.
Usually.
थोड़ा देर वेट करते तो शायद वो चला
हाँ,
जाता।
वेट करते तो चला जाता 2 मिनट में, एक मिनट।
पर चलो
ठीक।
Lugol-Sidin में भी तो दिख रहा है ना.
मैम
mustard.
endocervix, lugol,
एंडोसर्विक्स लुगोल-साइडिन नहीं
तो
लेगा ना,
नेगेटिव होगा,
एंडोसर्विक्स नहीं लेगा, वो तो
एंडोसर्विक्स
नेगेटिव
नहीं
होगा।
लेगा, वो तो नेगेटिव हो जाएगा।
She was having
अगर
discharge
endo
PV
है तो
probably.
बिल्कुल.
Yes, ma'am. Patient usually come with discharge PV. That's why patient.
Cytology is NILM, yes.
अच्छा ये बताओ Dr. Renuka, anybody can say. डुअल स्टेन भी आजकल कर रहे हैं साइटोलॉजी में.
मैम साइटोलॉजी में ना P16 एंड Ki-67 हम प्रेफर करते हैं.
Yeah, that is being done.
Yes, it can be done. Even in the
You can
biopsy
ask for it.
LBC में you can ask for it.
For high grade lesions, yes, for high grade lesions, if it is positive.
P16 positive usually recommended as high grade lesion.
चलो बढ़िया.
Very
Thank
nice.
you so much for such a lovely presentation. And thanks, ma'am Reena Srivastava, for staying till the end and clearing our doubts. And thanks, sweet and dearest Amrita, for being with us. And sweetie Renuka, my dear husband, and Diksha. Thank you all for
Yeah,
being
sweet young Renuka.
Thank you, Dr.
Yeah, thank you so much. Thank you.
Thank you,
everybody.
dear Deepti, Dr.
Thank you so
Chaturvedi,
much,
Dr.
ma'am.
Diksha, all of you. Thank you so much.
Thank you so much, ma'am, for being there. Okay, good night.
Bye, everybody. Good
Bye.
night.
Thank you so much. Thank you so much to all the dignitaries. And we are concluding this session here. Till then, stay safe, everyone. Thank you.